Good morning, everyone. Today's talk is on the increasing impact of imaging and especially cardiac MRI in the decision making in cardiology and cardiovascular surgery. So, as interventional cardiologists, we are constantly looking for new ways to increase the accuracy of our diagnosis and the precision of our interventions. With the growing role in assessing myocardial viability, fibrosis, congenital heart diseases, and cardiomyopathy, cardiac MRI has become an invaluable tool, making us more armed in making informed decisions tailored to individual patients. Today, this will be a case-based discussion in which I'll be, showing you a few cases in which we'll see how not only imaging but a combination of critical care thinking and cardiac MRI and imaging helps us provide, useful information in taking important decisions for a particular patient. These cases will highlight how proper imaging can help us make, accurate diagnosis, plan personalized therapeutic interventions for a particular patient, and finally offer prognostic insights that shape the long-term care strategies in particular patients. So this is the first case, a 52-year-old gentleman who presented to us with chest pain, dyspnea and palpitation, which he had 4 days back. On presentation, we got the investigations done and the ECG showed that the patient had an anterior wall MI. We got the angiogram done, which showed that the patient had total occlusion of the LAD, and when we did the echo, we found that there was a definite hypokinesia in the LAD territory onto the echo. So after the initial management here, the question we faced was how do we proceed forward, and whether the affected myocardium was still viable, and if revascularization would offer any benefit to this patient, considering the fact that the LAD is totally occluded and we have definite hypokinesia to akinesia on LAD. So the basic question is whether the LAD is viable and whether taking the risk of revascularizing this patient will really benefit the patient. We went ahead with the cardiac MRI, and what we found was the patient had transmural LG in the LAD territory that involved 6 out of 17 segments, and when we saw the T2 star values, it showed that they were low, indicating that the patient had IMH, that is intramyocardial hematoma, in the septal wall as well. So this finding was really very critical for decision making, because instead of pursuing very aggressive revascularization strategies which also carried a definitive small risk to the patient, we focused towards optimizing his medical therapy and thus prevented his further heart failure progression. The patient was doing well when he came on follow-up 3 months later. So cardiac MRI provides the opportunity for a comprehensive evaluation of patients with a history of MI. So a patient presenting with acute MI within the window period, he has to undergo PAMI, that is a clear-cut case. But whenever the patients present with the history of MI, that is MI before say 72 hours or 48 hours, we are left with a question on how to proceed in these patients, and cardiac MRI is an important tool to comprehensively assess these patients with regard to the extent of their disease, what is the impact on LV function, what is the degree of viable myocardium that is available, and how we can strategize treatment for this group of patients. This is the second case. She is a 68-year-old female who underwent CABG for her coronary artery disease almost 6 months back, and she had 3 grafts placed, that is Lima to LAD, venous graft to obtuse marginal, and venous graft to RCA. She presented to us with chest pain and raised cardiac markers, that is she had an NSTMI, and we can see the ECG did not reveal any specific localizing pattern. So we went ahead with an angiogram. Angiogram clearly showed that the native vessels were very heavily diseased, and the graft to OM and RCA were occluded, while the Lima was very well functioning. This was the echocardiogram. The echo showed that the patient had moderate LV dysfunction, with hypokinesia in the inferior wall. So here again we were left with a very critical question that how viable the myocardium left was, and secondly, which of the artery was clearly responsible for the ischemia. So here we have complex coronary artery disease. Patient has triple vessel disease with the native vessels being heavily diseased. Patient has undergone CABG, which is almost 6 months back. From that CABG, out of 3 grafts, we have 2 grafts occluded. So the question is everything viable? One. Second, if it's viable, then which of the myocardium is really ischemic, which would benefit by revascularization strategy? We went ahead with the cardiac MRI, and cardiac MRI clearly showed that the RCA was not only viable but was also ischemic, and hence the patient would really benefit by opening the RCA, whereas the myocardium supply for the OM was scarred. It had transmural scarring, so it was better left on medical management. The LAD was viable and non-ischemic. So by simple cardiac MRI, we could strategize the plan in this patient. So we went ahead with the revascularization of RCA. We opened up the RCA. The RCA showed very good result. There was good myocardial blush also. Post revascularization, the patient showed very significant improvement in her symptoms, and she was discharged in stable condition. She came on follow-up 6 months later and continues to do well with medical therapy. So post CABG patients with residual coronary artery disease, they are a complex subset of patients who require real thorough evaluation, and in this case scenarios, MRI is really helpful because MRI not only assesses the function of the LV, it also gives you an idea about the myocardial scarring, the viable myocardium, and the hemodynamically significant CAD. In fact, trials have clearly shown that MRI is superior to SPECT and in fact equivalent to FFR guided invasive angiography in terms of detecting the ischemic myocardium. This is the third case. She is a 29-year-old female who underwent orthotopic heart transplants, and 6 months later she presents to us with respiratory distress, persistent coughing and mild fever. She has altered laboratory parameters with anemia, raised total leukocyte count, raised creatinine and abnormal liver function test. This clinical constellation raises several diagnostic considerations, especially in post-transplant patients, which include infection, rejection, ischemia or drug toxicity. When we see the echo, we see that both LV and RV are severely depressed. There is moderate eccentric MR and there is moderate DR. We go ahead with the cardiac MRI. In this patient, cardiac MRI showed that there is globally raised T1 and T2 values with depressed both LV and RV function. And with these information in hand, we were able to reach a diagnosis of cardiac allograft rejection. We further poked the patient and we found that the patient had missed her immunosuppressive medications for several days, heightening the risk of acute rejection. So with this history and the information from MRI, we were sure that we are dealing with something called acute allograft rejection, for which we started the pulse immunotherapy and which led to successful resolution of the rejection episode. The patient responded well to high dose steroids and her clinical condition improved. Again, in transplant patients, MRI is a valuable non-invasive test for identifying any sort of transplant rejection. It allows the global assessment of myocardial inflammation and edema, and also helps in quantifying properly the LV and RV function. So if there is a rejection, there is always a global involvement of both LV and RV. Both the functions are depressed, and in both the ventricles you can have edema and inflammation, which are clearly detected by the tissue characterization technique of MRI. This is the fourth case. She is a 45-year-old female with 1 year history of breathlessness and palpitations, and she visited several consultants nearby, and were also partially relieved by the medical management she got. But despite the symptomatic relief, there was persistence and recurrence of symptoms. She had these repeated symptoms which warranted further investigation and evaluation, because she was getting relief with the local medications, but the thing was not getting settled. She had breakthroughs in her symptoms, and the symptoms intermittently increased. We can see the ECGs. ECG showed that the patient had almost bigeminy, multiple VPCs, and also had episodes of ventricular tachycardia. So angiogram was essentially normal, and you can see echo showed that the LV was globally depressed, as well as there was involvement of the RV as well to a little extent, and there was mild MR and TR. We went ahead with cardiac MRI, and cardiac MRI showed dense multifocal areas of LG, predominantly in the subepicardial and transmural location, and this was a non-ischemic pattern. Additionally, when we went ahead with T1 mapping, we found that the T1 mapping in the areas affected was really elevated, around 1700 milliseconds, which further supported the fact that the patient had myocardial fibrosis and granulomatous inflammation beneath that and we could reach to a diagnosis of cardiac sarcoidosis. Based on the clinical scenario we were seeing and the MRI findings, we made an impression of cardiac sarcoidosis in this patient, and the patient was put on immunotherapy, including steroids and azathioprine. The treatment led to the stabilization of arrhythmia. She improved in her function of both LV and RV, and her symptoms gradually resolved. She was discharged in stable condition, and when she came on follow-up, she was doing quite well just on prednisolone and beta blockers. So infiltrative cardiomyopathy again remain a real challenge, because these patients usually present with the symptoms which are very non-specific, and diagnosis can be really tricky. Cardiac MRI has shown immense promise in the evaluation of all types of infiltrative cardiomyopathy. Apart from identifying the morphology and the functional changes in LV and RV, because of its tissue characterization property, it can guide towards the specific type of infiltrative cardiomyopathy, and it helps us in not only assessing the disease but also in assessing the response to the treatment of these rare disorders. This is another case. He is a 56-year-old male who presents with 3-month history of giddiness and 1 to 2 episodes of syncope. The initial evaluation and the routine blood tests are normal. He is sent to UN for further evaluation because of an abnormal ECG. So when we see the ECG, we see that it is an LVH with strain pattern, and there is a high-grade AV block. We go ahead with the echo. Echo shows LVH with no significant valvular lesions. There is an LVH, but there is no aortic stenosis or coarct or any other valvular lesion. So now the question is, the patient has LVH, but LVH can have several causes. LVH is just a phenotype of cardiomyopathy, and you can have different causes for LVH. We include HCM and other disorders like rare disorders like storage disorders, for that matter. You can have Anderson-Fabry or Pompe's or Danon's. So if a patient presents to you with the LVH phenotype, you need to assess it, why the patient is having LVH. Is it hypertension? Is it some obstructive lesion? Is it HCM, or it is some type of HCM variant, as we just discussed? So we went ahead with the MRI, and in MRI we found that the patient had asymmetric ventricular hypertrophy with a maximum wall thickness of 18 mm. Additionally, we could see that there is an LG which was present in a non-ischemic distribution, which was consistent with myocardial fibrosis. The scar burden was around 20%, and this was really an important piece of information we got. So we got 2 important pieces of information in this case. One, that this patient has HCM, that is hypertrophic cardiomyopathy. So the reason for LVH was clear, that it is HCM. The second important piece of information that we got was the scar burden. The patient had scar, and the scar burden was around 20%, and this information again was important because the percentage of scar burden has a role in prognosticating the patient and deciding his or her treatment strategy. So again, the clinical picture and these imaging findings, they were really important in guiding the treatment in this particular patient. We went ahead with the dual chamber AICD and proper medical therapy, and he really showed good clinical response on follow-up, and there were no further episodes of syncope on arrhythmia in this patient. So as I said, cardiac MR is really important whenever you have LVH phenotype, because there can be several causes of LVH like obstructive valvular lesions, hypertension, hypertrophic cardiomyopathy, or rare storage disorder. And MRI, because of its ability of tissue characterization, helps us in differentiating different types of LVH phenotypes. And at the same time, it helps us in detecting myocardial fibrosis or scar, and the scar burden helps us in managing these patients differently in different subsets. This is another case. He is a 45-year-old male who underwent atrial septal defect closure almost 6 years ago and comes to OPD on regular follow-up. He is asymptomatic since the procedure and has no cardiovascular complaints. However, during the routine follow-up, what we see is on the ASD closure map, there is a mass. So this is the echo. As you can see, there is a huge mobile mass on the ASD closure patch, and given the location of that mass, it could be the thrombus, it could be an infection, it could be a part of infective endocarditis at large, or it could be a neoplasm. So we go ahead with the cardiac MRI, and we see that by the tissue characterization properties and the late enhancement feature, it was a thrombus. and this finding was really important in differentiating thrombus from other causes like the tumor or the infective endocarditis. Given the thrombus location and the potential risk for embolization, the patient was managed surgically. He was taken up for a routine surgery, and the surgery was performed successfully. The patient underwent a good post-operative care without any complications. On follow-up, the patient remained asymptomatic and in stable condition, and there was no further recurrence of thrombus or other issues related to the closure patch. So, for any cardiac mask, I believe CMR is a fundamental radiological method. It allows an optimal non-invasive localization of the lesion. You can clearly localize the lesion in any of the 4 chambers of the heart or even the great arteries. Moreover, because of the feature of its tissue characterization, with the help of MRI, you can differentiate pseudomasses from masses. That is, you can clearly differentiate different types of masses, like whether it's thrombus, whether it's fibroma, or it's myoma or hemangioma. These all features can be, because of the tissue characterization, we can easily differentiate these masses on MR and decide the treatment accordingly. This is another case, a nice case, 45-year-old male who presents to us with palpitation and pedal edema. Again, all the routine investigation, including the cardiac markers, they are normal, and the patient is referred to us for further management. Now, his ECG shows subtle changes in the form of RBB and T inversions in the anti-elites, but again, nothing definitive was obtained. Patient was little, you can say bulky. We didn't have a very good window, but as you can see on echo, there was no definitive finding to explain his symptoms of palpitation and pedal edema. We went ahead with an MRI, and MRI showed regional RV wall motion abnormalities, RV dilatation, and areas of fibrofatty infiltration within the RV. RV function was depressed with raised RV and diastolic volumes, and this really pointed towards the patient having ARVC. We went ahead with the genetic study in this patient, and we found that he had mutation in desmocollin 2, which confirmed the finding of ARVC in this patient. He was started on heart failure medications to manage RV dysfunction and prevent further decompensation. Additionally, we placed the AICD in this patient as he had a history of sudden cardiac death in the first degree relative, and following this comprehensive management, we were finally able to discharge him in a stable condition. On follow-up, he continues to do well with no recurrence of symptoms of palpitation or pedal edema. So you can see this was a very simple case highlighting the importance of one, a high clinical suspicion of a particular disease, and secondly, in choosing a proper imaging modality to help a patient. So this patient had very subtle symptoms of palpitation and pedal edema. Echo was essentially normal, because of the thick chest wall. We could not get a very good window, but it seemed to be normal, and but the patient had symptoms. And the ECG showed subtle changes, so we went ahead with a cardiac MR, and MR clearly showed that there was RV dysfunction with fibrofatty infiltration of RV, which confirmed that this was ARVC. Genetic study further added to the evidence that the patient had ARVC, which were responsible for his symptoms. Last but not the least, this is the very frequently faced clinical scenarios. This is a 55-year-old female who presented to us with chest pain, and tropi was marginally elevated. So was the ST segments in ECG. We went ahead with the angiogram, and angiogram was normal. Very common case scenarios. When we further took the history, the patient had history of fever for 2 to 3 days. We went ahead with the MRI, and MRI clearly showed LG in the anterolateral non-ischemic distribution, which was suggestive of myocarditis. So these are the group of disorder which we call MINOCA or myocardial infarction, which is present in the absence of coronary obstruction, and the differential diagnosis is really crucial in these group of patients to choose best therapeutic options in them. Cardiac MRI can identify the cause of MINOCA in almost 2/3 of the patients, and this really helps in managing these subset of patients. As we just saw, this 55-year-old female would have been on antiplatelet had the clinician did not have a very high degree of suspicion of some other disorder and had gone just with the angiogram. So this female really benefited with immunosuppressive therapy. Her LV function improved, and she did not have any episode of arrhythmia and was doing very good on follow-up. So again, the question here comes that is MRI is all that we need for the management of patients with the cardiovascular disease? The answer would be no. I would say that it is a combination of critical clinical thinking at the point of time and adding MRI to it that would really improve the management of patients with different forms of cardiovascular disease. Just to highlight this, we are presenting this case, which is a 56-year-old male who presents to us with palpitation and 2 episodes of syncope over the past 1 month. We got a workup done. We saw that 2D echo was essentially normal. An angiogram revealed that there is moderate disease in the LAD, but this was not thought to be severe enough to cause the symptoms. So we went ahead with the stress MRI, and stress MRI was normal. But the patient continued, to say that he is having those symptoms. We went ahead with the TMT, and the TMT, as we can see on the right side on the ECG, the TMT showed ST elevations. We went again ahead with the angiogram, and this time we saw with the IVUS that the lesion was in fact tight as compared to what we saw in the angiogram. So IVUS in this case and not MRI was able to solve the mystery and give us the correct path in managing this patient. IVUS showed that the lumen at that area of stenosis was very narrow and it was missed angiographically. So this case highlights the limitation of relying solely on non-invasive modalities like MRI and emphasizes the importance that comprehensive approach, vigilance, high clinical suspicion. This is all that we require in cardiovascular workups, which are, and this is the approach which is essential for making correct diagnosis and providing proper treatment to patients with cardiovascular disease. So these cases show high synergy between cardiology and radiology, can enhance the precision of diagnosis and allow for more tailored approaches toward specific patients. As I say, that guidelines provide a basic concept but for each individual patient you need to have a specific approach, use the concepts that are provided by the guidelines, and then apply in all group of patients. The collaboration between cardio and radio is required because it becomes more vital in complex cases where initial investigations are inconclusive and advanced imaging is required for a deeper understanding of the pathology. I would also like to say that in India we need a combined cardio-radio program. Then that would be that would be really important in solving cases and helping the patients out with the such rare forms of cardiovascular disease. By fostering collaboration between cardiologists and radiologists, we can set new standards for managing patients in our area. We can together push the boundaries of cardiovascular medicine and imaging and ensure that the patients benefit from the latest advancements in technology and expertise. Thank you all for your patient hearing. I would be glad to answer any question if the audience have.